Okay, good morning, everyone. We're going to get started. Today is November 17th. Our presentations by Dr. Nicole Dayton, our CA1. And thank you for those that are joining on Zoom. This is recorded, and if you guys have questions, whatever, throw them in the chat. Otherwise, we will give our attention to you. Cool. Let me try to get rid of this. There you go. You should be able to toggle either with the arrows or a space bar.
Okay.
Or like down here.
Okay.
Cool. So they can see that screen.
That screen.
Online. Yeah.
Okay, it's fine. I don't think I really need my notes.
Okay.
It's fine.
Okay, cool.
It's gonna be very informal. So we had a case, I don't know, last week sometime where there was an ABG that was like pretty textbook for a certain pathology, and there was one of the like newer training nurses that I think just had said they hadn't had a lot of experience with interpreting it. So we thought it might be a good thing to go through. I am gonna go into probably a little bit more detail than what is necessary, but I'm gonna try to like scan through the parts that aren't that relevant, just so that we know like this is other things that can be done with ABGs, but like is likely not something that's done as much in the PACU. And some of interpreting ABGs is like a internal medicine practice that they like to do just for like cognitive, thinking, because that's what they do and not as much like a surgical type of approach. So I'll try to point out when there's stuff that I don't think is like super relevant, but it's hard to talk about ABGs without going into like this kind of set step-by-step way of interpreting them. So all right, so in the PACU, I think there's a lot of benefits of getting an ABG. You get the results really quick. There's like a good amount of information that you can get from the ABG based on the numbers that we interpret, but also like electrolytes, there's a hemoglobin on it, there's a glucose, there's a lactate, things like that. So it actually can be a really good test. And it's something that's I say low-ish risk. If a patient has an A-line already, it's like pretty much a super low risk because you're just drawing it off of the A-line. If they don't have an A-line, it's still a fairly low risk, but anytime we put a needle into somebody's vein or artery, there's always some risk. So can't say it's always no risk, but certainly not a super invasive test in the grand scheme of things. So we don't think actually utilize them quite as much as I thought we would in the PACU, but it's a good thing to think about if we're kind of stumped, ABG or VBG as well, because those can also be drawn off lines depending on what you're looking for. So we had a patient, she was a 58-year-old female. She had recurrent adenocarcinoma of her left breast, and she was, coming out of the PACU after a left mastectomy. Her past medical history was heart failure, so HFrEF. Most recent EF was in May. They thought it was likely somewhat ischemic from a MI, but then also thought there was a component of chemotoxicity from her prior chemo for her breast cancer. CAD, she had a cabbage, tricuspid, basically a lot of cardiac pathology, and type 2 diabetes, hypertension, hyperlipidemia, CKD stage 3, but no like actual pulmonary like lung issues, no COPD, no asthma in this case, which we'll talk about, but that's kind of relevant. So on her operative day, she came in, her vital signs were pretty normal, but the intraoperative anesthesia team noted that her abdomen was pretty firm and distended. She had issues with ascites that they thought was related to her heart failure. She doesn't have any primary liver disease. So they go and do the case. We don't hear anything about it until the PACU bed request is placed. The floor runner comes out and is like, hey, I just want to give you a heads up about this patient. They're coming to PACU. They tell you all the medical history we just went through, and then just said, when they intubated, they had really low oxygen reserve, so SATs dropped really quick. They got the tube in, patient has done fine. Now they extubated, and the patient's kind of having trouble with oxygenation. She's pretty tachypnic and just struggling a bit. So they drew an ABG, and here it is. This was the ABG that we were given here. So we were like, oh, okay. And they tell you, yeah, they're gonna come back. They've got her on, face mask at, I don't remember how many liters, a number of liters, and they're trying to really sit the patient up. But just wanted to like let you know that they're coming. Great. So we'll take a pause from, we'll take a pause from that and go into kind of how the step-by-step of interpreting ABGs. So when you look at like any of the literature online, the first step is assessing the validity of the ABG, basically making sure the pH is consistent with what you would expect like the concentration of hydrogen ions to be. I have never once done this in actual practice, but if you're like, this ABG looks fishy, something doesn't seem right, you could do this to see, make sure that you don't need to like redraw it or something like that. But it's listed as a step. Then the next question is there alkalemia or acidemia present? This is pretty straightforward. Just looking at the pH, less than 7.35 is acidotic, greater than 7.45 is an alkalosis, because we'll talk about the ions as in a moment. So and then the next question you need to ask yourself is the disturbance respiratory or metabolic? So the things you look at are the PaCO2 first. So CO2 is correlates with, it's an acid, and then bicarb is a base. So when you have PaCO2 that is going up, the patient should be more acidotic, and if PaCO2 is going down, they should be more alkalemic. PaCO2 is associated mostly with your respiratory drive or your respiratory status, and so when it is a primary respiratory pathology, your pH and CO2 should go in opposite directions. If it's metabolic, your pH and CO2 change in the same direction. And why is that? Because the PaCO2 is changing as a response to the metabolic derangement, not as like the primary driver of what's going on. And often you might not see that the CO2 is actually abnormal in those cases, but if you had like a baseline ABG, you might see that it has changed in the same direction, but not necessarily be abnormal at that point, if that makes sense. The bicarb, so we already talked about the fact that it's a base, and you're kind of also asking yourself the question of like, does this explain the value of the pH? So if the pH is low, you have an acidosis, and the bicarb is also low, you can say that the bicarb is probably explaining the primary reason why patient's acidotic, and so that's likely a metabolic process. If the pH is low and the bicarb is high or normal or just doesn't explain that change, then it's likely a primary respiratory problem with plus or minus some metabolic compensation for that, and then vice versa if you have an alkalosis. This is a table that kind of shows which direction you think that PaCO2 will change. We'll go through each line, but again, we're going to try to like really boil this down, and I don't think memorizing this table is helpful at all. Because if you just think it through, right, it's easier than like memorizing, oh, that was up, and being able to fill in a table. So with this, you have a low pH, is it acidosis, alkalosis? Acidosis, right? And you have a high PaCO2. So do you expect that if you have more acid coming from the PaCO2, is it respiratory or metabolic? Respiratory, right? Because that CO2 is driven mostly by our respiratory, and in this case, you're kind of saying that the PaCO2 is driving the drop in pH. So respiratory acidosis. pH is low. Again, we already said acidosis. PaCO2 is low or normal, then what are you thinking? Yeah. And again, these are not like hard and fast rules, because ABGs can be weird, but it's just like giving us clues as to what might be going on more likely. And I'll just like skip through this because it's basically just the opposite. pH is up. We're in alkalosis, and PaCO2 will be, and bicarb will tell us if it's primary respiratory or metabolic. I put these, I think they're sending out the slides, so I'm going to skip through it for the sake of time, but I think you guys will get these slides if you want to actually look into it. Fourth step, and this is really where I think like we're starting to get into like this internal medicine brainy thing that we like probably don't do very often. There's a bunch of formulas that you can use to say, okay, we've determined what the primary problem is that's going on. Now, is the patient actually compensating effectively for that primary disturbance, or how much would we expect their, respiratory system or their, metabolic system to compensate for this? We're not going to go through all of these, but this is what the medicine people do upstairs. and it is interesting. Like, I actually ran a couple of the examples, and it really actually does work. Sometimes not, but it's interesting that we have the ability to do this. And if you really need to know, like, if they have more than one process going on, which is pretty frequent, you can sort it out through some pretty simple plug and chug math. But I think this slide, things to note is essentially, like, sometimes if it's a metabolic process or a respiratory process, some of the numbers won't make sense. Like, you'll be able to determine this is primary respiratory, primary metabolic. Then you're like, but the bicarb or the PCO2 doesn't seem like it's, it's where it should be based on, like, compensation. So if you have a primary respiratory disorder and your bicarb is higher than you would have expected it to be, like, you're like, oh, but the bicarb's also, really high, and you probably have some sort of metabolic alkalosis, right? Because bicarb's a base in addition to whatever respiratory disturbance you have. If it's lower than expected, then you probably have a metabolic acidosis. Essentially, boil it down to be bicarb's higher, something your metabolic system is also going on aside from the respiratory thing. If your PCO2 doesn't make sense based on the metabolic problem, then there's probably something respiratory going on. And then, if CO2 is high, it's a respiratory, PCO2 is acidosis, right? Yeah, or low. Does that make sense? Did I boil it down fine enough? High bicarb means metabolic alkalosis, low bicarb, metabolic acidosis, PCO2 high, respiratory acidosis, low, respiratory alkalosis. So you can kind of, do it a little bit less with all the math there, but just thinking, like, those are the core things to remember about it. And then whenever there's a metabolic acidosis, the medicine people will get really interested in the anion gap. And sometimes we might too here if it's relevant, but there's this, like, I feel like I can't do an ABG talk without talking about mud piles, because it's like a thing that, I don't know, we learn, it gets drilled into our brain in med school. But I would say if you have a metabolic acidosis and the anion gap is high, the things here in PACU that are probably relevant, DKA and lactic acidosis, I think you guys probably see the most frequently here. The other stuff is like emergency medicine kind of deal, more relevant for that. Again, I think this is just more detail than is necessary, but you could see DKA, and certainly you guys see high lactates a lot here. Okay, so we run these steps briefly with the case that we're in. So we don't need to go through this because it was just a plug and chug, but essentially if you plug and chug to see the concentration of hydrogen for this patient, it actually worked out, which I thought was kind of interesting. You can't see it here, but her expected hydrogen was 57 between 7.2 and 7.25, and she is. So it's like, wow, math works. That's cool. Okay, so alkalemia, acidemia for this patient. Correct. And then would you guys call this primary respiratory or metabolic? Yeah, right. PCO2 is super high. Yeah, for this patient, for sure. So PCO2 went up. This is one where, like, the bicarb's normal, but when I looked back from prior, it had gone up. And so it's on the higher end. So I think she had some compensation, but I'll get into a little bit. Basically, our bodies have a harder time compensating for primary respiratory problems. That happens more slowly. So if it's an acute respiratory problem, you won't see as much compensation, versus if you have a metabolic problem, you can very easily change your respiratory rate and the compensation happens quicker. Okay, we're not going to go through whether it's compensated for, but I did run the numbers and it's kind of somewhere in between. So it was a little bit confusing. But I think what's relevant is you see this ABG and you're like, that looks bad. What might be going on? So here are some examples of things that could be going on if you have an acute respiratory acidosis or a chronic. We can, everyone can read through the list. I think things that probably are more common to think about here, CNS depression from different drugs. So we give a lot of opioids here, and we all see our patients fall asleep. We don't get ABGs on all of them, but they fall asleep and they stop breathing or their respiratory rate goes down. They probably, over time, if that continued, they would have like a similar ABG to this lady. And then the other one that I wanted to, COPD, we have a lot of patients with COPD here. Some of them are chronic. I would put here acute is under, exacerbation is under acute, but then chronic COPD, there you could see an ABG like the one she has, except for that the pH is normal. And you're like, what? But it's because she like chronically just retains CO2. So the thing that I wanted to talk about with this was this patient, basically something that can cause respiratory acidosis, anything that's going to reduce the respiratory rate or your tidal volume or ability to actually like deliver oxygen or exchange oxygen and CO2 in your lungs. Post-op, people are at risk for atelectasis. They're at risk for not breathing enough. This patient was lying on her back for the entire surgery and had a bunch of ascites that was like shoving up on her lungs. We have a lot of really obese patients here that also pushes up on their lungs. Any of that could cause, in the addition to like when you start compounding all of these things onto one another, which is what we do here, could cause this sort of picture respiratory acidosis in the right setting. So while it seems like maybe the most common thing that we see here is lactate, I think these respiratory problems are really common. We just don't necessarily always get an ABG or recognize that it could be going on in these patients. So how do we treat it? Basically, we want her to breathe more because we want her to breathe off that CO2. And then we also want to like pop those airways open, expand her lungs. So basically increasing her respiratory rate and or her tidal volume or like ability to exchange from whatever atelectasis she has from all of that being shoved up on her lungs for her whole case. So what do? We sat her up, then you have gravity working toward or with you, right? Titrate the O2 in the meantime because she still needs to be saturating well. Minimize opioid use. So for her, it was like, you balance pain versus like, are they splinting from pain versus we don't want them to stop breathing. So it was kind of a tricky balance with her, but she wasn't in a ton of pain. So we minimized how much opioids we were using and made sure she had Tylenol and all the other supplemental pain stuff that's not sedating. Incentive spirometry, although I know you guys are all too familiar with the fact that sometimes patients' oxygenation can't tolerate like time off of the oxygen to actually, do the IS, but if they're on nasal cannula, it's okay. And then basically the reason why the floor runner came to give us a heads up on this is because it was like she might need to be escalated to CPAP. So you're doing all these preventative things. That's not working in this case because we believed it was an atelectasis sort of issue. CPAP would have been our next step. So thinking about that, what's the worst case scenario if this doesn't get better? How are we going to escalate to make sure that this patient is oxygenating well? Oh, and Lauren did a really wonderful job of just like waking the patient up. Don't let them sleep. Like wake up, breathe. So sometimes just those simple things can be enough. And with this patient, we sat her up, kept her awake, constantly reminding her to breathe. She was on oxygen, rechecked the ABG and was improved. And she did fine and she didn't need CPAP. So again, conservative things first, but they're always thinking about escalation if it were to be needed. Next, I just kind of wanted to go through some other examples of things that I thought could be seen here. So yesterday, this was actually in pre-op, but I like changed it a little bit. There was a 32-year-old male, history of end-stage renal disease on, I think had just started hemodialysis or something, actually had a chronic like metabolic acidosis from kidney failure. They got a VBG in pre-op and this is what it was, which is a little confusing. Sorry, it doesn't have the little arrows that tell you what's high and low. Made it harder, I guess. So I guess going through it, first thing, is this an acidosis or alkalosis? Alkalosis, right? And he typically is acidotic from his renal disease. Respiratory or metabolic? So his PCO2 is very low. His bicarb, I think that's like low normal. Yeah. So when Dr. Ketterpal showed me this ABG, because he knew I was doing this talk, and he's like, here, look at this one. And I was like, what the heck? Like, this is really, really weird. Then he told me patient has panic attacks, anxiety, and he is very nervous for his procedure. So things that we think about with an acute respiratory alkalosis, things that you guys see a lot, pain, right? Patients are like, I have so much pain, I have so much pain, like, and they're just breathing really fast. Panic attack, same thing. That's why they're like, people are supposed to breathe into a bag so that they like maybe breathe back in some of that CO2. I don't know if it actually works, but you know, you see it on TV at least. Sepsis or fever, right? A lot of times people get tachypnic with that. Some sort of CNS infection, stroke, basically anything that's going to like drive somebody's respiratory rate up. And then the chronic ones, I think, not as important here. So how do we correct that? Oops, I have an extra slide in here. I mean, basically, again, the goal is the opposite. Try to get the patient breathing more slowly. I think if they're doing fine, you don't necessarily need to like try to correct it right away. But if the patient's in pain, treat the pain. You know, he was nervous. I think they probably gave him his Madaz. Kind of try to talk through some breathing exercises. Let's slow the breathing down. But I think often, I don't know how often this is like, oh my gosh, we need to treat this urgently, right? But it can give you some indication of what's going on. Try to get them in a more comfortable place. Obviously with sepsis or fever, things like that, you're gonna have other problems and other derangements. So we just have to treat the underlying problem there as well. That's an extra slide, okay. And then this was something I wasn't here for, but this happened last night, and so I added it in this morning. 80-year-old female had a laparoscopic right colectomy and sigmoid resection. I think it was for cancer. In the PACU, the patient was like doing totally fine, thanking everybody for what they did, and then abruptly lost consciousness. Nurse called for help, tried to get the blood pressure cuff cycling, can't get it to cycle. On-call resident was luckily sitting right there, came, pushed some pressor, they get a blood pressure cuff reading of 60/40, call staff stat. The team continues to try to resuscitate, push pressors, and an ABG is drawn. Acidosis, alkalosis. Yeah, respiratory or metabolic. Metabolic, right? Bicarb super low. The PCO2 is actually a little bit low, or sorry, no, this PCO2 is not high. So, but I don't think that's as relevant here. And then we know that lactate, like lactic acid, will make somebody have a metabolic acidosis, and in this case, the lactate was super high. So metabolic acidosis, to go back to this chart here, I think, you know, in this case, it was probably this lactic acidosis kind of picture. So I want to talk a little bit about lactate, because I think that's often a question, especially if it's like yesterday we had a couple and it's like, oh, it's 3, and they just had a big operation. We've resuscitated. It's like, what do I do with that? It's not super high. Seem to be doing okay. Obviously, this lady was not doing okay. But things that cause postoperative elevated lactate, low cardiac output state, so hypovolemia, whether that's under resuscitation or bleeding. In this patient's case, she was bleeding. She went back to the OR for an XLAP. She actually, you know, they actually found that, I think fairly quickly. They figured it out, but under resuscitation, I think, is a big thing. I think the first step often here is like, let's just try to give a little fluid and see if that helps. Obviously, any sort of shock, it's the same sort of deal. Your organs are not getting enough perfusion. They're not seeing enough oxygen. And so you get a lactate bump from tissue hypoxia, bowel ischemia. These are all pretty much the same kind of concept. The one thing that I thought about to bring up though is because we do a lot of ortho, and I don't know how much, so I didn't know this until I started doing ortho, and they're like, hey, anesthesia, can you put up the tourniquet? And then at the end, like, can you put the tourniquet down? And I hadn't really thought about it, but that limb then is ischemic for like, I mean, sometimes they have these tourniquets on for like over 2 hours. They're like, please add more time, please add more time. And I'm like, the heck, that's been up for a long time. And obviously they know it's safe. I'm not as familiar with like how long can a limb be ischemic, you know, to be safe, but they've done it a lot. They do this every day. But what we see in the OR when they bring that tourniquet down is sometimes like pretty profound hypotension, because all of that like lactate and those like metabolic products that are built up in this ischemic leg while they're operating then like recirculate into the body, and they get this kind of like response in their blood vessels that just like dilates them, and then they can get like pretty profoundly hypotensive. If so, we have to make the decision, do we want to treat this knowing that it's probably going to improve, like is it that low, or do we want to just kind of let it ride out knowing that they'll come up? But if you were to get an ABG on these patients post-op, I think it's possible, if not probable, that you'd see a little bit of a lactate bump just from a tourniquet if it was on for a long time. So kind of a relevant thing. What's that?
Like they take the tourniquet off and they leave. They're like, no problem.
Yeah. Like,
yeah.
But I think it's just pretty common for lactate to be elevated for a lot of reasons post-op, and sometimes it means something and sometimes it doesn't, but the fluid's usually the first step. But I think it's also important and helpful for us if you guys are thinking about like what badness could be happening. Like that patient that was there, hers progressed really quickly, and then they didn't have an ABG on her prior, but had her lactate been rising and rising, we have to consider like, is this patient bleeding? Is there some sort of ischemia? Like if it's a vascular procedure, did they accidentally block flow to their entire bowel or something like that, and their gut is dying? Like those things we have to identify quickly. And so something doesn't seem right with the lactate, if it's climbing super high, fluid's not really helping, it's just worth, you know, running through a checklist of like, let's make sure some terrible thing is not happening with these patients, and it's helpful to have more brains thinking about that. And then ultimately, you know, treating the underlying cause and giving it time. If you're like effectively re-resuscitating the patient, the patient that was there went back to the OR to, you know, stop the bleeding. The tourniquet thing's probably it's just time their body will process that, those byproducts. But whatever the underlying cause is, ultimately what's going to fix lactate is treating that. But I think take home point is just usually we start with fluid here, because usually if there's lactate bump, it's probably just they haven't eaten or had anything to drink since 6 p.m. last night, and it's now 5 p.m. today, and they need more fluid than what was given. So questions? Anyone want to talk about something, things that you guys have seen?
Like hours, or
I don't think so. I mean, sometimes I've seen it come back up by the time we leave the OR. What we struggle with is like often these ortho patients end up on a little bit of fennel, like a fennel drip. And so there's been times when I'm like, can I turn this fennel drip off? Because I don't want to take them to the PACU with a fennel drip. I know it's going to get better, but like, you know, then they don't take the tourniquet down until literally like sometimes after they close. And so then we're turning off the propofol, which will help with their blood pressure, but takes a little bit, and you don't want to get stuck in the OR. Like, I don't know, it's just like a weird balance that sometimes happens. But I don't think it lasts super long time. I don't know, because then we drop them off in PACU and I'm like, see ya. Which maybe I won't do that anymore, like, or as much now after like sitting in the PACU. It's like, oh wow, maybe I should treat pain better in the OR. Like maybe I should think about how I do things in the OR. But I don't know the exact answer to that, but it shouldn't be sustained for a super long time. Yeah, that's a good question though. Yeah, and I don't know.
I never thought of that.
Yeah.
You see now that we have this big blood shortage, we used to give out blood like a lot more. Do you think that has an impact on any of these things? Because like it used to be when you would do a hip would usually always get a blood transfusion, and now like nobody gets a blood transfusion.
I don't know.
Like,
Yeah, I feel like we can't drive our decision making on like how much blood we have,
right.
but
I think you're too young to know what it was like.
Yeah,
when you used
I
to
think-
get blood. Really sick.
I think though too, like, because we had a talk in our tutorial on like blood transfusion or like product transfusion reactions, and it's like I think there's been a lot more research and a lot more conversation about what is the risk benefit like in terms of giving blood or not giving blood, and what can, like, it's not a benign thing to just like give blood. Bad, like terrible things can happen with it.
We used to give somebody, like, we used to give people, like, I worked in ICU, give them tons and tons of fluid. And
Yeah.
just in the 5 years that I worked there, like, we went the opposite way where it was like, they did so much better when you didn't bombard them with fluids, whether it was crystalloid or just like LR. Like, people did so much better when you weren't all puffy. So
I think it probably has more to do with
but like, it's not, but we usually do like, because it's like, I want your blood pressure to look better, but it's like, it was almost, you get better results just kind of riding with a lower blood pressure than giving them, you know, like, yeah. Right, like our livers used to like, you're like, I replaced everything. You're like, you're gonna pour RBC. Really?
I think it's probably the lesser number of people that get blood transfusion, and has more to do with like increasing knowledge surrounding this doesn't actually help that much, and it's like it's not a benign intervention versus we don't have enough blood to give people. But you always have to ask, like, is stuff like that impacting it? Because I don't know. But we have gotten more lectures, or we have gotten a few lectures about the risks involved with transfusing, and there was a huge push, like when we had to rotate up on medicine and cardiology, that really over transfusing or keeping people's hemoglobins high by giving blood products just for the sake of like being more comfortable with that number doesn't improve outcomes, and actually might like worsen outcomes, because then they could have even like a mild transfusion reaction or something like that. So they are very comfortable upstairs. Like if it's 7.1 and they're not a cardiac patient, we're not gonna do anything about it. So cardiac patients, they do 8, I think, is the transfusion threshold. So I don't know. I think it's just like a change, like a cultural change, more so. But yeah, that's all I have. And I have pictures of our dogs. This is
that looks like a calendar picture.
Yeah. Yeah, I took so that shadow over there, she's a German Shepherd, and then Reaper's in the middle, he's a Belgian Malinois, and then Mizzy we got in May, she's like a 3-year-old hound dog. Reaper had a little bit of fun this spring, and then we had a lot of puppies. So there's the puppies. I know. I know. Yeah, we had 15 puppies at our house. Because both of the females got pregnant. And so there's like the shepherd Malinois mix like down there. And that's the hound Malinois mix there. We just ran them around Target Park. We live on, like, we have some land, so we were able to, yeah. Yeah, there's a lot. So anyway, cute dog pictures. I know, times 18. Yeah, he Yeah, he was there for some of it, but he hunts a lot, and so there were times when he was gone, and I was.
Oh my God. They wouldn't have like a trough.
Yeah.
We found homes for a number of them, and then once it started getting cold, he drove them to Arizona to be with his parents because he was like, I'm gonna be gone, you're working like 13 hours a day. They're with his parents. Yeah.
Wow, those are some little pure ones.
I know. Yeah, they're good, but there's not that many left. I think there's like 5 left. So it's good. We're making progress, but they're pretty cute. It's hard to not like want to keep all of them. Anyway, that's all I have. Yeah.
Oh, and cute sharing.
Oh wait, there's a chat. Oops. Sorry, you guys. On Zoom, there was a chat question. Increasing IV fluid. Felina, are you still on? I don't know if she is.
If you text the response, it stays up there.
Okay, perfect. I don't know if I know the answer to this, so probably it could. Oh, yeah, but I wonder if she's asking specifically in the context of like the tourniquet. And it might depend too, if like on how well they're.
In which instance are you referring to?
Yeah, we can look that up. Maybe somebody can look that up. Oh, it looks like Trisha's talking. I just can't hear anything.
Our Trisha.
Oh. I should stop recording this because. Okay, thanks everyone.